The North American subgroup analysis of the ECHELON-1 study was evaluated largely because of potential regional differences in the outcomes in Hodgkin's lymphoma in the primary ECHELON-1 study presented by Joe Connors at the American Society of Hematology last December 2017. In the full study, the global study, which incorporated a large number of countries around the world, there was a 5% benefit for patients who received the experimental arm in modified PFS. The aspect that was interesting is that benefit was not equally distributed globally. When we looked specifically in North America, there was a larger proportion of patients that benefited, 10 to 12%, as opposed to the 5% with the experimental arm, and there was an improvement both in the success of the experimental arm compared to international results, and the outcome of the control arm or ABVD arm. I think it's unclear why that benefit exists, but certainly the number of patients on the North American subgroup analysis was substantial. This accounted for approximately 40% of all the patients on the study, and this was a 1,300 patient study in the ECHELON-1 evaluation. So it was not, I think based on this, is unlikely to be a statistical anomaly. That being said, it is a subgroup analysis and must be evaluated prospectively to be confirmed. But the difference is more than double what we saw globally and may suggest a benefit for AABD that is larger in the North American component as opposed to other parts of the world. I think there can be several reasons for this. There may be biologic differences in the disease. There may be differences in metabolism of drugs regionally, and there may be differences in practice patterns between countries that may help us better define what is maybe the best way to use AABD moving forward.